Dear colleagues, welcome to today's Acute Cardiovascular Care Association webinar on acute cardiovascular care during the COVID-19 pandemic. I'm Professor Kurt Huber from Vienna, Austria. The aim of this webinar is to give you a better understanding about diagnosis and treatment of COVID-19 positive patients with respiratory failure, changes in the organization of STEMI and non-STEMI networks in the COVID-19 pandemic, including diagnostic and treatment strategies of patients presenting with acute coronary syndromes, a pronounced prothrombotic milieu associated with a COVID-19 lung infection, thus leading to thrombotic complications, options of end-of-life decision in the severest ill patients, and to inform you about ongoing studies in order to fight the virus. For this purpose, we have prepared a program with the following topics and experts. Respiratory failure, what is special, will be presented by Professor Christian Hazaguer. Pre- and in-hospital care of ACS patients by Professor Pascal Franks. I will present about the prothrombotic milieu in COVID-19 positive patients, which may lead to thrombotic events. The deciding end of life is discussed by Professor Eric Bonfoy. And Dr. Alexandru Mishi will talk about current research in therapeutic options. After watching the webinar, participants will be able to diagnose and treat COVID-19 positive patients presenting with respiratory failure, understand changes in diagnosis and treatment of patients admitted for acute coronary syndromes, how the prothrombotic situation associated with the COVID-19 infection may aggravate clinical outcome, and which preventive measures should be taken, consider options of end-of-life decision in collapsing systems, and be informed about ongoing studies. Now I will hand over to Professor Christian Hazaguer.
Hello, my name is Christian Hazaguer. I'm going to give a talk on the respiratory failure and what is special about this COVID. I have no conflicts of interest regarding this issue. And I'd like to start to mention that the COVID infection is not just another flu. Initial Chinese data showed that if you have a pneumonia and goes into the ICU, your chance of survival is less than 50%. So it's a serious condition. How does it differ from an ordinary flu? Well, the SARS virus has to enter the cell by connecting to the ACE2 receptor. And the ACE2 receptors are placed deep down in the lung, while the flu actually binds to the upper part of the airways. So this may partly explain why we have these deep infections. The ACE2 receptors is also placed many other places in the body, for instance, in the endothelium. We do have some early disease knowledge about how it affects the histology of the lung because of a coincidental infection with patients who underwent lung lobectomies for adenocarcinoma. And there the authors mentioned that on top of a lot of inflammation, the alveolitis, there's also a lot of fluid in the alveoli, protein-rich fluid. So perhaps it's also a injury to the vascular endothelium causing a capillaritis. And this fits actually with the clinical experience that you get very rapid decline in the health of the patients once in a while. Another thing that is a little different is that known pulmonary disease before you get your infection is actually rather rare. In China, it was only 1% who had chronic obstructive pulmonary disease in the first 1,000 patients treated there. And if you take those that die from the disease, also data from China, chronic lung disease was only a minor part. You can see it is ischemic heart, diabetes, hypertension. It's these comorbidities that often fare worse on this disease. This has been redone in other places of the world. In New York, for instance, 5,700 patients, chronic obstructive pulmonary disease, only 5.4%, and in Italy, only 4% had COPD. So all in all, it is not primarily patients with known pulmonary disease that gets this severe infection. Another thing that's worth noting is that the time to improvement is very long when you get these infections and get into the hospital. This is data from one of the first randomized trials on this disease. Just to note that if you go into the hospital and have to have some oxygen, only after more than 2 weeks, only 50% of the population has improved. So time to improvement is very long. What is also coming to these patients is that they very often need oxygen, a lot of oxygen, but often in the beginning, at least, without CO2 problems. This is 2 X-rays from 2 different patients at our hospital. And unlike usual ARDS, we see severe hypoxemia and near normal respiratory compliance. This means that the patients are clearly dyspnoic, but they don't feel it that much themselves because they can just increase their minute volume in the beginning. The CT findings is often in the beginning ground glass opacity, like this all over this lung and here. And then later on, it becomes more consolidated. So in the beginning, usually only one lobe and ground glass appearance. Soon thereafter, bilateral and in the periphery. And then after a couple of weeks, you get more consolidations, and pleural effusion is a rather late phenomenon. This is data from 81 patients with repeat CT scans from China. And you can see this is the same as I showed on the former screen. Ground glass opacity is very common in the beginning, unilaterally, suddenly it becomes bilaterally, and you get more and more consolidation or mixed findings, more severe findings later on. So another way of putting it is that the ARDS of the COVID-19 is an L type in the beginning and an H type later on. It starts out with low elastance, that means normal compliance. The lung is not difficult to extend, and then you have low ventilation to perfusion ratio. Apparently, the hypoxemia might be due to the fact that the vasoconstriction normally seen with low oxygen is somehow paralyzed. You have low lung weight and only ground glass densities here in the beginning, and low recruitability because there's a lot of air in the lung. Later on in the disease, you get low compliance, you get a lot of shunting in these areas, and the lungs are heavy. It's typical AIDS lungs. And here you can recruit more lung tissue. So how do the experts then ventilate these patients? This is data from Italy, showing that on their 1,000 patients, they on the average used high settings of the inhaled oxygen content, as you can see here. And they also used a relatively high PEEP in order to try to recruit lung tissue, on the average almost 14 centimeters of water. If ventilation during a normal setting is not possible, you can prone the patient and ventilate him upside down. This is recommended by many physicians treating these patients, and it's actually normally we do that for 16 hours and then you turn onto the back for the next 8 hours like this. But there are specialists saying that you should do it even longer, for even longer period with this infection. The thing is, you get more uniform ventilation with the lungs. We are not meant to lie on our back. We are meant to either crawl forward or stand up. So you have more uniform ventilation when you lie in the prone position. And just as a note, if the patient gets cardiac arrest, you give CPR with the patient lying prone. You don't have to turn it around first. A colleague may have a fist in here to counterbalance. Obviously, this is not a COVID patient because you can see they are not wearing the protection they need. So if I should sum up, the coronavirus enters through the lower part of the airway. It is not primarily chronic lung disease patients that gets this infection. The time to improvement is rather long, more than 2 weeks on the average if you need oxygen at a hospital. So it's a long time in the hospital for many patients. Initially, you see severe hypoxemia and near lung compliance. So you see these hyperventilating patients which are feeling okay because they don't have to use that much of their muscles to breathe in the beginning. The CT finding on the initial CT is often ground glass opacity, which then goes into more consolidated lungs later on. The patients need a high FiO2 on the ventilators and a high PEEP, and you can prone position ventilate them if needed, and even for longer period than usually used. Thank you very much for your attention.
I'm going to discuss today with you the pre- and in-hospital care of ACS patients in the age of COVID-19. When looking to COVID-19, there were some illustrious cardiologists making some expressions. The first one was Hector, that was pointing this finger on the wound, indicating that people might be terrified in coming to a hospital, and especially to an emergency department in this age of COVID. Rod Stables went even one step further, indicating that potentially the deaths due to postponed care would be even worse than the deaths related to COVID-19 directly. In all cases, we have to convince our patients that our hospitals remain safe shelters. In order to do that, we have to think in two principles: clean versus dirty. So any movement and transport of patients with COVID-19 out of an isolation room should be avoided unless medically necessary. If a transport is medically necessary, we have to use designated routes of transport that minimize the exposure of staff, other patients, or visitors to potential infection. We always have to notify the receiving area when we leave with the patient from the isolation area and indicate the time of arrival of the patients so that the acceptance area can be prepared. Potential transmission of COVID-19 is a challenge, and it's a challenge because it might even be transferred to other people by asymptomatic patients. Of course, COVID-19 patients are most infectious when they are showing symptoms. When dealing with COVID-19 in the in-hospital or out-hospital settings, we have to take in consideration potential cases. And the expression goes, when I see a bird and it walks like a duck, it swims like a duck, it quacks like a duck, I call that bird a duck. So when dealing with patients that present to you with anosmia, loss of smell, cough, fatigue, diarrhea, shortness of breath, fever, dry cough, these are patients that potentially are cases of COVID-19. So we have to be really prepared and anticipate clinical signs or symptoms of the disease. Of course, when dealing with patients with COVID-19, we need to have a test strategy as well. It's, of course, about the clinical symptoms and signs, but as indicated already, some of these patients are even contagious when they are asymptomatic, so we need also a test strategy. And the gold standard in the test strategy is the reversed PCR technique. But we have to be aware that false negative tests are really a clinical problem. These tests have a high specificity, but a low sensitivity. So 30% of the patients, even having clinical signs or symptoms, may test negative at the first testing, and even at the second testing consecutively 3 to 5 days after the first testing. So in our hospital, we merged the testing with PCR technique, so the laboratory gold standard, with imaging. And we use for that CT imaging because it proved to have a higher sensitivity versus the PCR technique, however, a rather low sensitivity. We can discuss this, we can agree on this, but this is at least a technique or a test strategy that we developed in our region. When the patient is transferred from outside the hospital or from another hospital to our setting, at the arriving of the patient, we provide the patient with a surgical mask, either during the transport or upon arrival in the hospital. We develop or we perform a PCR testing, a swab, even in the ambulance. So if the patient is coughing, it doesn't spit on the emergency department or in the corridors, but it stays inside the ambulance car. So we create a close environment to do the testing. And we combine the testing with the CT scan. So upon arriving in the hospital, PCR testing and chest CT scan. And this is how our test strategy in our center, in our region looks like. So if a patient with an ST segment elevation myocardial infarction or a high risk non-ST segment elevation myocardial infarction is presenting to our hospital, either coming from in the hospital, from a spook hospital, or from outside the hospital by own admission, by his own car, or through ambulance, we first assess the patient if the patient has a COVID-19 case. Is the patient known with COVID-19, yes or no? If the patient is known with COVID-19, the patient is transferred to a dedicated COVID cath lab and to a dedicated COVID ITU after the intervention. If the patient is not known with COVID-19, so we have certainty that the patient was tested either the day before or the day that he was admitted to the hospital and was proven negative on CT scan and on the swab, so on the PCR testing, then the patient goes to the non-COVID cath lab and the non-COVID ITU department. If, however, we are unsecure, we don't know, then first we say, okay, is there any suspicion of COVID-19 in the patient based on clinical signs or symptoms? We do a test swab, again, for PCR. If the patient has clinical signs or symptoms that are consistent with COVID-19, but until now, no proven test, even then the patient will go to the COVID-19 cath lab and is transferred later on to a COVID-19 ITU. If the patient has no clinical signs or symptoms, so is totally asymptomatic, no symptoms of anosmia, no coughing, no fever, then the patient is transferred to the non-COVID cath lab. Please recall that the patient has a surgical mask. The procedure is performed, and from the cath lab table, the patient is transferred to a chest CT At the chest CT, if the CT is negative, then the patient is going to a non-COVID ITU. If the chest CT, however, is positive, the patient is transferred to a COVID ITU. Chest CT positive means there are clear signs on the chest CT that we are potentially dealing with viral pneumonitis. So if the patient is transferred to the non-COVID ITU, the patient is still kept in a kind of an isolation from the other patients until we have the PCR swab. Is a PCR swab negative, then the patient is cleared and is moved to the other room, to another room in the non-COVID ITU department, where the patient is dealt with as if it was a normal patient. If, however, again, the PCR test is positive, then the patient is transferred also to the COVID ITU. If we are dealing with a non-ST segment elevation myocardial infarction, we have much more time. At that moment, upon admission of the patient is brought to chest CT, and again we look if there are any clinical signs of COVID-19 pneumonitis. If so, the patient goes to the COVID cath lab. If not, we perform again a test. If the test is negative, then the patient is going to a non-COVID cath lab, non-COVID ITU. Is the test positive? Again, the patient is going to a COVID cath lab and a COVID ITU. So the big difference between the non-STEMI, non-urgent, quote unquote, is the fact that you have time to do the testing. And again, in our center, it's a combination of PCR and chest CT. And the chest CT in the non-ST segment elevation myocardial infarction is just to try to capture these patients that are contagious, but that we don't catch with the PCR technique. Very important as well, if we are dealing with patients with ST segment elevation myocardial infarction or non-ST segment elevation myocardial infarction, is that these patients sometimes might be unstable. And sometimes these patients might need intubation and ventilation, or even non-invasive ventilation. But we have to be sure and to be certain that these patients might create aerosol in the cath lab. For that reasons, we think that non-invasive ventilation is of high risk of aerosols in the cath lab and should potentially be avoided. If we think that the patient might destabilize during the procedure and need mechanical ventilation, it's better to anticipate and intubate and ventilate the patient even outside the cath lab, because intubation of a patient with COVID-19 creates a lot of aerosol and might contaminate the cath lab room. If a patient needs to be intubated in the cath lab, you better close the cath lab for 1.5 hours to 2 hours after the procedure before cleaning, in order to really clean the room before starting another procedure. Important as well is that intubation and ventilation of a COVID-19 patient is a really high-risk endeavor, and you should not hesitate to contact a senior anesthesiologist in order to help with the procedure. And while dealing with these patients, you have to protect yourself by wearing the proper personal protection equipment. Speaking about PPE, and here I'm showing one of my collaborators in the ITU department, PPEs in dealing with a COVID-19 patient is about eye protection. It's about wearing a gown, an overall, or a disposable plastic apron, a fluid-resistant mask or respirator, and disposable gloves. The eye protection you can use for one procedure, then you have to clean it, especially if you have intubated or ventilated the patient. The fluid-resistant mask might either be an FFP2 or 3, according to the fact if you're going to create an aerosol environment, yes or no. And of course, disposable gloves, that's the ones that we regularly use in the cath lab or in the ITU department. There are different types of surgical masks, different types of ventilators, and again, what we are aiming for is the FFP2 or the FFP3 in aerosol environment, or when dealing with a COVID-proven patient. While dealing with a patient with suspicion, there a surgical mask can be enough. Important as well is, and this is for our collaborators that were sick themselves and were infected with COVID-19, important for them is when they're wearing a mask, and they're wearing a mask with a filter indicated with the arrow, they can protect themselves, but they can spread disease to other people in the early phase after they came back from their sickness. So this is not the type of mask I would advocate to be used in a cath lab environment. So I would avoid to use masks with filters like this on the mask. When finishing up with the procedure, the room has to be cleaned. And really the virus, the COVID-19 virus, is a very sensitive virus. It is an enveloped virus that can be destroyed easily by more than 80 disinfectants. The most effective remains alcohol or bleach. And this can be used to clean a room, and whether or not in combination with local disinfectants to clean more sensitive elements of the cath lab. And there, soap and detergent can do a lot of the job. Thank you so much, and thank you for having me in this COVID-19 webinar.
Dear colleagues, my task is to talk about the prothrombotic milieu in COVID-19 positive patients, which may lead to aggravation of clinical course caused by thrombotic events. With this presentation, I have no disclosures to report. The contents of my presentation include the epidemiology of thrombotic events, the pathophysiology of thrombus formation during COVID-19 infection, diagnostic biomarkers for detection of thrombus formation, preventive and therapeutic antithrombotic treatment, and finally, a take-home message. In this slide, you can see the cumulative incidence of venous and arterial thrombotic events in COVID-19 pneumonias in patients at an ICU. And the event rate is about 30 to 40% and starts very early. You can see this clearly from this slide. In this slide, you see the venous thrombotic events in a series of 81 patients with a severe COVID-19 lung infection. In these patients, about 25% developed venous thrombosis and about 1/3 died, which shows you clearly the aggravation of the basic disease. I would like to focus your interest on two markers that are frequently measured in these patients. First, the APTT, the activated partial thromboplastin time. This is significantly elevated in patients with VT compared to patients without. And if you look at the D-dimer, it's also significantly elevated in patients with compared to without VT. I come back to these two biomarkers a bit later. Now, what you see on this slide is a typical sign of pulmonary embolism in times of venous thrombosis. On the left-hand side, you see the typical ground glass opacities for the lung infection with COVID-19. You can further see fibrotic streaks here in panel B with these small white arrows here on the bottom. And you see on C a typical sign for vascular dilatation. On D, you see a thrombus in the right pulmonary artery. On the right slide, another case, a CT image in an axial plane. and you can see a bilateral pulmonary embolism with thrombi in the left main pulmonary artery and a thrombus in the right interlobar artery. Why does thrombosis occur in these patients? So the main and most important explanation is a severe inflammatory reaction. And as you can see from this slide, here you see the mRNA expressions of genes related to cytokines and their regulating factors. I just would like to focus our interest on two of these genes, which is interleukin 10 and tumor necrosis factors. Both genes are known to be able to induce thrombus formation. And on the other hand, these patients with a massive inflammatory reaction, they have also a reduced immune system. For example, the CD8 expression is reduced for 44.6%. The CD8 in combination with CD16 and CD56 expression is reduced for about 60%. And if you add CD19, so the immune system is reduced for about 70%, in addition to an increased inflammatory reaction. The same mechanisms also are responsible for arterial thrombosis. We have some reports just a few weeks old from New York with this massive pandemic situation there, where several strokes were reported in different vascular territories, as given in the upper part of the slide, including the right internal carotid artery, left middle cerebral artery, right posterior cerebral artery, again left middle cerebral artery, and right middle cerebral artery. And the most important information here is that at least 2 of these 5 patients had no COVID-19 symptoms at all. Also, the development of acute myocardial infarction, also called non-coronary myocardial injury, is a typical sign in patients with COVID-19 infections. This is a type of arterial thrombosis, and as can be seen, if you look here at the biomarkers, peak troponin I and peak troponin T are significantly elevated in patients with true myocardial infarction as compared to patients with only non-myocardial injury. But also D-dimer, which is important to detect deep venous thrombosis and pulmonary embolism, is significantly increased in patients with true myocardial infarction compared to myocardial injury. And one of the interesting outcomes here is that in both situations, the mortality was very high, 50% in myocardial infarction and up to 90% in patients with non-coronary myocardial injury, which again clearly tells you that there is an aggravation of the lung infection. What are the reasons for non-coronary myocardial injury? Vasospastic angina, stress cardiomyopathy, myocarditis, and lung infection or PE itself. Now, this slide shows you the pathophysiologic mechanisms that we think that are really important in thrombus formation. On the left-hand side, upper part, the alveolar space. Here you can see the virus, and the virus activates monocytes. Monocytes have tissue factor on their surface. There's also an activation of cytokines, and all these mechanisms together lead to thrombin formation, finally fibrin thrombus in the alveolar space. At the same time, this inflammation goes interstitial, as can be seen here, and it comes down to the capillaries. And in the capillaries, you can find damaged endothelial cells, and again, activated monocytes with tissue factor on their surface, an activated cytokine system, and thrombin and fibrin formation. Now, this theoretical picture is shown in the next slide with respect to a histologic investigation. In this patient who died from COVID-19, it could be shown in panel A and B that there are so-called viral inclusion bodies. This is this circular small bodies. In the tissue, this is kidney tissue. In the same patient, small bowel specimen was investigated with hematoxylin eosine staining, and you can see here mononuclear cell infiltrates. And in panel D, you see beside mononuclear cell infiltrates also neutrophil infiltration. And with a specific staining, with the so-called caspase-3 staining, you can also see apoptosis of endothelial and mononuclear cells. Now, with respect to biomarkers, plasma D-dimer is the typical marker to show an increased thromboembolic situation in the body, especially in patients with deep venous thrombosis and pulmonary embolism. So in this series of 43 consecutive COVID-19 positive ICU patients, it could clearly be shown that the levels of D-dimer in patients who develop pulmonary embolism are much higher compared to patients who have no sign for a venous thromboembolic event. And another important information is that the higher levels of D-dimer, the higher is the mortality in those patients. You see here in orange the non-survivors, and here the D-dimer levels compared to patients who are survivors. These patients usually have very low D-dimer levels. So I would like to come back to the prolonged APTT that is frequently seen in patients with lung infection due to COVID-19 infection. And what can be shown here is that in patients with a prolonged APTT, you have in about 90% a positive lupus anticoagulans, which is responsible for a prolonged APTT. But this means, on the other hand, that you should not hold back antithrombotic therapy or fibrinolysis in COVID-19 positive patients with a prolonged APTT, because there is, just based on this finding, no prolonged bleeding risk. This slide gives you the preventive anticoagulatory measures in hospitalized COVID-19 positive patients. This has been published by the University Hospital of Leuven in Belgium. And as can be seen in patients who are admitted to the ICU and in patients who have no reduced kidney function, a full dose of low molecular weight heparin, 50 international units per kilogram of anti-10A twice daily should be given. For example, if you use enoxaparin, this would be at least 4,000 international units anti-10A twice daily. Only if the patient has a reduced kidney function with a creatinine clearance of less than 30 ml per minute, then these doses should be halved. In patients who are on ECMO or on a continuous veno-venous hemofiltration, instead of low molecular heparin, unfractionated heparin should be used. If a patient is non-severely ill and is not admitted to an ICU, so the dosage for prevention in patients with or without reduced kidney function is 50 units per kilogram of anti-10A once daily, which means enoxaparin of at least 4,000 international units anti-10A once daily. This is the follow-up VTE prophylaxis in COVID-19 patients. Here it's important to measure anti-10A levels, and if a patient is on the ICU, is severely ill, a daily morning blood monitoring for anti-10A is important. This should be done at least 8 to 10 hours after the last dose of low molecular weight heparin. We should aim for anti-10A levels of 0.15 to 0.4 international units per ml for prophylaxis and 0.4 to 1 international unit per ml as a therapeutic dosage. In non-severely ill patients on a non-ICU ward, 1 or 2 times a week, the control of anti-10A is usually sufficient, and it aims exactly at the same dosages for prophylaxis and therapeutic strategies. This is an interesting slide. This is not a clear recommendation by guidelines, but in many of these very severe ill patients with COVID-19 lung infection, you see multiple microemboli in the lung. And one situation that eventually can be treated, this situation that eventually can be treated by a TPA bolus, a fibrinolytic therapy. In this case, you see patients in the upper, you see the partial oxygenation in these patients. It's very low. And as soon as TPA was given first by a 10 milligram bolus, followed by an infusion, 2 milligrams per hour. So this oxygen saturation went up tremendously. And at the same time, the need for catecholamines went down. So this is few cases reported, but we should think in certain individual cases that a fibrinolytic therapy may help to save the life of the patient. My last slide is the take-home message. Severe COVID-19 lung infections are frequently accompanied by venous or arterial thrombotic events, as deep venous thrombosis, pulmonary embolism, stroke, or myocardial infarction. That may aggravate the clinical course. It's important to say that this is not characteristic for the SARS-CoV-2 virus alone. It can also occur with other pathogens if these lead to severe lung inflammation. Thrombotic events are caused by massive inflammatory mechanisms and at the same time a pronounced prothrombotic milieu. An optimally dosed anticoagulation strategy is mandatory in COVID-19 positive patients, not only for treatment, but especially for prevention of thromboembolic complications. The potential benefits of systemic anticoagulation, however, have to be weighed against potential bleeding hazards and should be individualized. I thank you for your interest.
Dear colleagues, my name is Eric Bonnefoy. I'm a physician working in the Acute Cardiovascular Care department of the Cardiology Hospital in Lyon, in France. And when we are discussing or deciding end of life, we are speaking about a collective project centered on a patient and shared with a family and a team. It requests time and peaceful environment. When something goes wrong, it generates a lot of suffering. And during an epidemic, many things are going wrong. We have this 79-year-old man with an ischemic cardiomyopathy and an ejection fraction around 40%. He is admitted in an intermediate cardiovascular unit from the emergency department because of dyspnea, fever, hypoxia, and the low cardiac output. His clinical status improved with treatment. SARS-CoV-2 is suspected and confirmed with PCR. 24 hours later, he presents an acute worsening of his clinical status, and now he's on invasive ventilation, norepinephrine, with a SOFA around 8. He's supposed to go to an ICU and to benefit from an ICU bed and a ventilator because he cannot stay in the unit where he is now. Is it possible? Should it go there? And this is what we are going to discuss now. First point is the question, is he at the end of his life? And this question is relevant with 3 considerations. The first is imminent death, whatever the treatment. It is not sure there because we are just at the beginning of the management of this patient. Presumed basis of an overwhelming poor outcome. It is not an item relevant here because it is more in the setting of acute cardiac arrest and brain injury following this arrest. So the third point is lethal condition. Yes, he has a lethal condition, but this ischemic cardiomyopathy, low fraction ejection, is not a short-term menace and more a mid-term problem. So we have to balance the basic presumption of prolonging life, one phase of our mission, against offering a peaceful and dignified death That is another phase of our mission. Deciding end of life and discussing this point is a common situation in intensive care. Already in normal time, resources are limited, and withdrawal is considered in at least 60% of those who are dying in an ICCU. But an important point is that there is a large variabilities between countries, between hospitals, between teams within the same hospital and physicians within the same team. And this is well illustrated in the figure on the right. This figure depicts the distribution of around 50 ICCUs in Europe in red, or the States in blue, according to the proportion of patients whose death is associated with withdrawal. And this large variability hints at the fact that during an epidemic, many teams will have a lot of ethical concerns. As physicians, we are not that good at short-term prognostication, and it is a problem too. We tend to overestimate short-term survival, and we are much better at a range of prognostic rather than to say, yes, no, this patient will survive or not in the hospital. Other members of the health team are slightly better at recognizing imminent death. And overall, the accuracy is much better when made by a multidisciplinary team. During an epidemic, additional factors will prevail in resource allocation. The goal will be to save the most lives as possible with a shortfall of means, scarce resources, and so to exclude those patients who will have the highest probability of survival without ICU and ventilator, and also those who will have the lowest probability of survival despite this treatment. And to do so, some points will have to be followed. First, early estimation of survival on predefined criteria. And then strict exclusion criteria from this treatment, and in time trials. Time trials meaning that there will be a periodic assessment of their clinical status and an estimation of the pursuit of treatment, especially on ventilator, and if the patient will be allowed to stay in the ICU. A third point is independent triage decision makers, be it triage officers or triage committee. Their purpose is to allow the attending physician to go for his duty to care and not to be confronted to the decision to allow or not the patient to benefit from a ventilator or an ICU bed, or to be discontinued from this treatment. And this is framed by specific guidelines to preserve the duty to steward resources, that is to balance the interest of the community of patients against the obligation to care for a specific patient, the duty to distributive justice, that is, like cases are treated all alike, and transparency for everybody, and to limit emergency planning and conflict of interest. And these will put a lot of psychological stress and ethical tension on the care team. Concerning the communication with the family, the recommended approach, that is the shared decision-making process, is a well-balanced process that allows for the family the patient and the care team to support each other in making decisions around the end of life of the person, of the patient. During an epidemic, this process is not possible. And it is not even the other approach, that is a paternalistic approach, with where the clinician decides alone the fate of the patient, that will be used, because decision will not be made in the best interest of the patient, but in the best interest of the community. And this will also be a source of ethical tension and psychological stress. Regarding the key components of good end-of-life care, they will also be jeopardized during an epidemic. What will probably be kept is some kind of overall support for the family through family speech and from the care team, the possibility to express statement ensuring non-abandonment, ensuring symptom controls, that is, that the care will be centered around the comfort of the patient, and ensuring decision-making, that is, that there is some care plan that can be shared and that will be shared with the family. The shared decision-making process will be difficult. Family presence at time of dying will most probably not be possible during an epidemic, and perceived nursing skill that is very important for the family will also not be available for them. During an epidemic, the state rulers will be driven to impose strict rules concerning confinement, concerning social distanciation, and also specific rules for the management of the dyings and the management of corpse. Here in 1918 on the left and the current situation on the right. Moreover, there will be a large disruption of family and social links, be it voluntarily or again imposed by the state. Maintaining communication will be difficult and rest on phone calls and other means of often web-based, more sophisticated communication tools. They will try to replace face-to-face meeting, and then they will have to obey the same rules and norms that are used when going for face-to-face end-of-life meeting that are highly structured. It means that they will have to follow the same structure and the same rules regarding their vocabulary. They will be strongly remembered by the family, and often it will be all what the family will be able to handle. And they will also contribute to the stress experienced by the physician. What is also very important is that all these communications are linked together and will be focused towards the last one, the last call announcing the death of the patient. And it will go, this last call, much better if there is a good relationship that has been built with the family during the previous call. If the death has been prepared and is not unexpected, and if a physician, not necessarily a senior physician, it can be a nurse, it can be a junior physician, as long as the call explains the details of the death and is done with empathy. The technical aspect of withdrawal of treatment are well framed by guidelines provided by the palliative care societies or intensive care societies. And they will allow to to go for the end of life and to death with guaranteeing the comfort of the patient. What has to be known and told to the family is that in the setting of a severe pneumonia, death will occur rapidly after withdrawal of respiratory support, especially mechanical ventilation. This will be my last slide. Burnout is a constant menace in acute care, be it cardiovascular or general intensive care. It will be especially a preoccupation with during an epidemic because of the larger number of deaths, because we will not have the usual support of the family, and also because end of life will be largely and associated with withholding or withdrawing treatment and additional factors of stress. So beware of the symptoms of burnout if you are working long hours, especially night shift. Do not accept to enter conflict in any situation, and beware too of preserving very good relation within the team. Beware too of the effects of social disconnection in relation with confinement. Most surveys show that after around 1 week, 10 days, that are very difficult and very stressful and very difficult. Positive emotion will prevail in a large majority of members of the care team, but also a large minority will continue to suffer. So it is very important, and we have to emphasize the need and the utmost importance of the support from colleagues, from relatives, from friends, and from all sectors of society. And as regarding our patients, actually it is you who will decide according to the stage of the epidemic you are in, the guidelines that are going in your institution, and also the rules that prevail in the because of the health administration and the decision that surround that. So we are not the one who will actually decide the end of life of the patient, nor unfortunately the family. Thank you for your attention.
Hello, my name is Alexandre Michy. I am cardiologist at Centre Hospitalier de Montluçon in France, and I have the pleasure to present to you a current research project for the COVID-19 pandemic. Currently, there are 3 mega trials launched in March against the COVID-19. One of them is Solidarity, which is conducted by the World Health Organization. The other one is the Discovery trial, which involves mostly European countries. And the third one is a UK trial named Recovery. These trials investigate similar drugs, but maybe in different doses. So Remdesivir, Lopinavir, Ritonavir, and hydrochloroquine, also interferon beta. We will have the results of these trials in a few weeks. What drugs can we use in the fight against COVID-19? Over here, we have a very beautiful review in the German network regarding the drugs that we can use. And on the left side, you have the pathophysiological mechanisms of the virus and eventually the drugs that can be targeted. So we can use either repurposed drugs, either investigational drugs or adjunctive therapies. you have here a table from the same article which resumes what are the repurposed drugs that we are using currently. A few lines about hydrochloroquine. For the moment, the results have been neutral. This drug has shown its efficacy in vitro. However, clinical studies failed for the moment to bring very clear proof that this drug works. However, there is increased concern regarding the risk of QT interval prolongation associated with the drug. Concerning lopinavir/ritonavir, we have a study published in New England Journal of Medicine which shows that there was no benefit concerning this drug in COVID-19 patients. We also have investigational drugs. One of them is Redemsivir. There are two papers which have been published, one in Lancet, which didn't show a clear benefit for the COVID-19 patients, and another article published in New England Journal of Medicine, which used compassionate Redemsivir, and the data interpretation was very challenging. However, the third trial seems to be a positive trial for Redemsivir. So this is the adaptive COVID-19 treatment trial. And an interim analysis showed that Redemsivir was better than placebo for the primary endpoint, which was the time to recovery. There is also a survival benefit which this drug brings. And this announcement was made on the 1st of May by the FDA. We also have adjunctive therapies such as tocilizumab, which showed positive in one trial, which is the CORIMUNO-TOCI trial. So an interim analysis showed that a significantly proportion of patients reached the primary outcome in the tocilizumab arm, which is the need for ventilation or death at day 14. You have the doses here and the study design here with the links if you need to access the article. Immunoglobulin therapy means the use of convalescent plasma or hyperimmune immunoglobulins that contain antibodies to COVID-19 virus. There are currently 7 trials recruiting on clinicaltrials.org, and the FDA has issued recommendations to healthcare providers and investigators on the administration and study of this product. Now, do the existing drugs that have shown in vitro antiviral activity achieve adequate plasma pharmacokinetics with currently approved doses? Dr. Arshad and colleagues recalculated the 90% maximum effective concentrations, EC90, value for each drug. Only 14 of the 56 analyzed drugs achieved a Cmax EC90 ratio above 1, meaning that the plasma Cmax concentration exceeded those necessary to inhibit 90% of the virus replication. We also have some sort of breaking news, a very interesting article which was published on the 30th of April, showed and brought us a new interaction map of COVID-19 protein revealing targets for drug repurposing. Researchers from US and France identified 332 high-confidence COVID-19 human protein-to-protein interactions that could be used to block the virus. Among these proteins, they identified 66 human proteins or host factors targeted by 69 drugs, which are either existing FDA-approved drugs, drugs in clinical trials, and/or preclinical compounds. You have the link here if you want to access the full text. On the left side, you have the SARS-CoV-2 protein-to-protein interaction network from the same study. The authors concluded that the following classes of molecules were effective in reducing viral infectivity. Protein biogenesis inhibitors, for example, totatifin, ternatine, plitidepsin, which is also used to treat multiple myeloma patients, and is currently under consideration by the Spanish Medicine Agency for a phase 2 trial in hospitalized COVID-19 patients. We have ligands of the sigma-1 and sigma-2 receptors, like haloperidol, this product right here, PD144418, hydroxychloroquine, and PB28. This is a product which is 20 times more potent than hydroxychloroquine in the fight against the virus. We have also sigma R1, R2 active drugs. I would just like to highlight the progesterone, which could explain why men appear to be more susceptible to COVID-19 and more often suffer for severe complications. Once again, this study was published on the 13th of April. A few lines about the vaccines. I will present the trials which are enrolling right now. We have the AstraZeneca trial, which uses this product. We have a Moderna trial involving the mRNA 1273 product, with an estimation primary completion date on the September 2021, so in 1 year. We have the BioNTech trial. Very interesting, we have the Sinovac-Biotech trial, which is enrolling right now, and the estimated primary completion date is August 13, 2020, so in just 3 or 4 months. And we have 2 more vaccines from our colleagues in China. The results will be available in at least 3 or 6 months, more likely 1 year. There is also research concerning BCG vaccines, so several trials are undergoing right now. Researchers are wondering if this vaccine could prevent the spread of the virus. My last slide is about the a real life survey. So 203 physicians were asked what are the drugs which are the most used for COVID-19 in hospitals. So this is the result. Most of them use acetaminophen, antibiotics, bronchodilators, hydroxychloroquine, plasma, ibuprofen, and very few use remdesivir and antivirals. Thank you very much for your attention. Stay safe.
We are now approaching the end of this webinar. Many thanks to our speakers, Professor Christian Hazaguer, Professor Pascal Franks, Professor Eric Bonfoy-Cudras, and Dr. Alexandru Mishi. We hope you enjoyed this time with us. Thank you for your interest. This is Kurt Huber from the Acute Cardiovascular Care Association of the ESC.